Okay, my name is Levi Vere, and allow me at this point also to acknowledge my student guide, Mr. Blackstone Pitolo, who helped me also with the study. Okay, so we carried out a study titled The Role of Workplace Exposure in HIV Transmission Amongst Healthcare Workers at Public Hospitals in Zimbabwe. And going straight into the summary or synopsis of what we did. If you can help me scroll down. Okay, so really a cross-sectional prevalence survey was conducted, and really this was based on the null hypothesis that there is no difference in the rate of HIV infection amongst healthcare workers and the general population. So this really was the null hypothesis that we were endeavoring to support or not to support through the study and through the evidence collected through, during the study. And what we found out from the study was quite intriguing and interesting, because we realized, of course, that the prevalence or the infection rate amongst healthcare workers was actually higher than that in the general population. And you know, if you can help me to go down. Thank you. All right. Okay. So we discovered that there was that difference, which sort of helped us to actually reject, through statistical inference, to reject the null hypothesis in favor of an alternative hypothesis that, in fact, there is an association between being a healthcare worker and the HIV status. Right, so basically the difference in rate of infection between the general population and the healthcare worker population was actually attributed to the difference to workplace exposure through this study and through the design of the study. Really, this obviously is quite important, we felt, because really this would help folks involved in HIV prevention programs and strategies to help to figure out ways and means of instituting preventive measures at the workplace for healthcare workers, and strengthen those public health prevention methods as well. At the bottom of that slide there, we have shared sort of how the study was designed overall. You will notice that a total of about 400 structured questionnaires were shared through a cluster. It was actually a multi-stage cluster, random sample of 400 participants, or 400 potential respondents. 183 of those of the 200 healthcare workers responded, and with the usable questionnaires, and 181 non-healthcare workers responded with usable questionnaires. And what as I have already indicated earlier, we noticed that 33 of the 183 healthcare workers actually had HIV infection, as compared to 21 non-healthcare workers that had no disease. So moving right ahead, so what exactly were we endeavoring to achieve, and what exactly was the problem that we were trying to solve through the conduct of the study? As we have already noted, the null hypothesis that we had come up with in conducting the study was that we wanted to see if we can support or not support the null hypothesis that there is no there is no difference in the rates of infection between the general population and the population of healthcare workers. However, it is already known, so this really is the justification of why we had to conduct the study, and really the problem statement as well. It is already known that potentially, and from surveillance and studies that have been done in other cases in other areas, that the prevalence of HIV amongst hospitalized patients is higher than that of the general population outside the hospitals. So the thinking here is that obviously the healthcare workers are in contact more with this group of this part of the population, which is expected to have a higher prevalence of HIV anyway. And some of that, the methods or means by which infection can potentially move from the hospitalized patients to the healthcare worker is through splashes, cuts, needle stick injuries, and so forth. Sort of accidents that we see from time to time in practice as healthcare workers as well. So, and really, we already know that there are some efforts to try and mitigate the problem that results from that exposure. For example, the use of post-exposure prophylaxis or use of personal protective clothing as well. However, we already know from other studies that there's a lot of stigma around HIV and just knowing somebody's HIV status, and so what has been seen also previously is that although there is post-exposure prophylaxis offered to persons or to healthcare workers that have been splashed or that have had needle stick or cuts and other contact to body fluids or to infected patients, we realize that because you actually need an HIV test, a pre-test before going on the post-exposure prophylaxis. Some healthcare workers actually opt to not report when they are actually exposed in any of those ways. As well as also we have noticed also that even though some actually go through the post-exposure prophylaxis, they may not actually finish the treatment. So they'll probably take the treatment for 14 days instead of the full 30 days. So there is that really describes some of the problem that encouraged us to want to know what really could be the importance of this exposure in contributing to the acceleration of the HIV epidemic within our communities. Okay, going to the next page. Right. So for a little bit of background, we would all understand that the HIV prevalence in sub-Saharan Africa is what has increased. I mean, from the 80s when the epidemic was first discovered, peaking around the mid 90s towards the end of the millennium, and then thereafter through public health efforts as well as treatment with lifelong drugs, there has been a reduction in the sort of the prevalence of HIV over time. However, we all know that even at this point in sub-Saharan Africa, HIV prevalence still hovers around over 10% in most of these countries, including Zimbabwe, where this study was carried out. And however, this study, so with all the various prevention methods and to try and mitigate the spread of the HIV epidemic, we and the interest through other organizations, for example, WHO, the UNAIDS, and PEPFAR, who are participating in all these prevention, public health efforts against the HIV infection, HIV epidemic. It is one of the strategies that is being used now, is to actually try and look for those areas where public health has not exactly yet reached, or where we are not doing so well. And one of the areas really, as a background, is as a background to this study, and the justification for the study was really the area of the workplace, because we were of the feeling that the workplace is really like a reservoir for HIV, given that the proportion of patients with HIV, or persons with HIV within hospitals increases, because this is really where hospitalized patients tend to then eventually come to. So really a focus on possibility of nosocomial or hospital-acquired HIV infection becomes very important in trying to zero in on those areas that may not be getting so much attention as all our efforts to reaching epidemic control go forward. Okay. It is already known, for example, that needle stick injury through other studies provides a risk of almost 0.23% for possibility of HIV infection. Now, really, this led us to ask a number of questions. Essentially, number one, what is the current occurrence? So we wanted to know the current prevalence of HIV amongst healthcare workers as compared to the general population. We also wanted to know what the relative risk as well as the attributable risk of being a healthcare worker for HIV infection, or in simpler terms, just to understand whether if being a healthcare worker was related or associated with HIV infection. So and lastly, we also wanted to know, having established whether or not being a healthcare worker was a risk factor for HIV infection, we wanted to know what demographic factors amongst healthcare workers were also related or associated with the HIV infection status. All right. And so what were the methods that we used to carry out the study? First and foremost, this obviously was a cross-sectional point prevalence study. So really at a point in time, we wanted to know the prevalence of HIV in the two groups. As you recall, at the beginning, we noted that we had two groups really, the healthcare worker group and also the non-healthcare worker group, which was acting sort of like the comparison or control group. The general population in this case was represented by the non-healthcare workers, but these non-healthcare workers are not health workers working outside the hospital environment. The reason why we selected non-healthcare workers that were working within the hospital environment was we wanted to sort of curtail or deal with possibility of selection bias, or the fact that maybe any differences that we may observe in prevalence are due to healthcare workers knowing more, say, about HIV and so forth, and being maybe more careful, you don't know, than the general population. So we wanted to work with those that are, a control group of persons that are as closely meshed as possible with healthcare workers. One of the other worries that we had in designing this was around recall bias, and so fortunately both populations were expected to have equal level of recall, so that sort of fell away. And then I think another thing also that was worrying us was around confidentiality and the interest generally of persons participating in this study. Given that it has to do with HIV. But some of the things that we did is we really discussed initially, and really sort of educated the respondents about the reason why we wanted to do the study, and also that really the study was, it was going to be anonymous, so no one was required to write their name. One of the other ways also was I, as the researcher, and the persons that were assisting me, which were really department managers within the hospitals, where they all signed oath of confidentiality slips so that to give confidence to respondents that their information was private and confidential as much as possible. And also on submission of the um, the responses or the questionnaires by respondents, these were put in envelopes and thrown into a response box. So really it was not handed over to myself or any of the other persons that were assisting me. Okay, so we also used methodology called Cochrane's method of proportions for determining the sample size. So we noticed that we needed about 180 participants for each group. We used the cluster sampling technique, and we can talk about this if anyone is interested in knowing more about how exactly we did the sampling. But a total of 400 questionnaires were sent out, expecting about 90% participation. And we managed to actually achieve 91%. From there, we of course carried out or did some descriptive statistics where we noticed, for example, that the proportion of persons that were HIV positive amongst the healthcare workers was actually higher at around 18% compared with the general public, which was around 11.6%. So we were able to we noticed this difference, and we needed to obviously do test of inference or significance to see if this difference was really large enough for us to be able to reject our null hypothesis. So you notice that the t-test for proportions was carried out using the central limit approximation to the normal distribution of the binomial distribution. We used also chi-squared test to be able to find associations between the status of being of being a health care worker and the HIV status. We also did use the chi-square test also to determine if there were any associations between any of the demographics, healthcare worker demographics, with the status of, not with the status of being being HIV positive, but with exposure to methods or to HIV itself. So in the questionnaire we asked questions like, did you did you ever get splashed at the workplace, or did you ever get a needle stick and things like that? So we wanted to see if any of the demographics are more or less related to that kind of methods of exposure. What results did we see? As I have already stated earlier, we saw a difference in the proportion or in the rate of infection between the two groups, with a higher proportion amongst healthcare workers of about 18%. And when we conducted a t-test of proportions, we noticed that this was at 5% significance level. We noticed that this was actually significant at a p-value of 0.049. And the chi-square test for significance of association between being a healthcare worker and and the normal population, we realized that also there was significant difference with a p-value of about 0.037. We also, as I mentioned earlier, wanted to determine attributable risk, and we noticed that this was up to 43% amongst the population that we investigated. What demographic variables were related to HIV to exposure? What demographic variables were related to exposure? We noticed that the work shift, which means what work shift a healthcare worker was in when they got maybe a needle stick injury or got splashed and so forth. It seemed that this was the work shift was related to the exposure method, the various exposure methods. Also, the type of career, whether you were a laboratorian, or you were a doctor or a nurse, or you were working as a cleaner or things like that within the hospital, or you were a pharmacist. There was a difference amongst those professions, so there was a significant difference. And also work experience. So we also realized that there was actually a difference in infection, in exposure rates amongst persons of different work experience, right? But we didn't see any difference with age and sex. In conclusion, we noted, of course, already that there is a difference in prevalence between the two populations, healthcare workers and the general population, represented, of course, in this case by non-healthcare workers who worked within those hospitals. So we really eventually rejected our null hypothesis and actually accepted the alternative hypothesis that healthcare workers are actually at a higher risk of infection given the settings in which they work. There's obviously need to, and so this is really the recommendations that came out of this study to the Ministry of Health, that there is need obviously to reinvigorate the public health prevention methods to prevent occupational HIV exposure. And particularly looking at the fact that things like work shift, the type of career and experience of each health care worker had an impact on whether or not they are exposed, and eventually, of course, exposure would lead to infection as well. Okay, and really, in terms of future steps, the study, we recommended that a study of occurrence of workplace accidents was needed as well, a separate study on that. And also we were looking also at a possibility of conducting an incident study, really an example, for example, being a cohort study which follows maybe HIV negative healthcare workers through time longitudinally, to find if really persons may identify maybe a particular point in time when they are actually infected through workplace exposure, rather than for them to be using recall to identify potentially that they were infected in the workplace or not. And also we were recommending that we would want to know maybe the direction of the various associations. For example, to say, is it when you are older that you have less chance of being exposed, or is it when you have worked more hours at the workplace? Particularly looking at those demographic factors that had an association with infection.
So dear participants, please vote for Mr. Levi for the presentation done on the topic, the role of workplace exposure in HIV transmission amongst healthcare workers at public hospitals in Zimbabwe. So dear participants, please vote for Mr. Levi on the background of public health specialization.